is
not on mine.
lipid-based. It's lipophilic, and it can freely move inside, into and outside the cell through the cell membrane. It doesn't need a receptor to get it into the cells like protein hormones. It just diffuses into the cell. Once it gets into the cell, it attaches to a receptor within the cytoplasm. That receptor in the cytoplasm transports it through the pores in the nuclear membrane inside the nucleus, where it attaches to specific gene sites. That attachment will cause that attachment into those genes will cause them to either increase or decrease their function. So that's what this thing is saying right here. You get the cortisol into the nucleus, and it will actually increase or decrease the function of certain genes. One of them that it will decrease the action of is the regulatory mechanisms that determine glucose uptake. You guys went over the GLUT transporter proteins, so this is part of that. It deregulates those. Because of that, it will increase the serum glucose, especially in somebody who is already having trouble with regulating glucose. You'll see their blood sugar soar if you put somebody on steroids. So eventually getting to the diabetes range. If I gave you an injection of a steroid, Depomedrol, Solumedrol, anything like that, I'm going to jack up your blood sugar temporarily. That's why you have to be careful if you get somebody, if you get a diabetic who's not well controlled, coming in with poison ivy, and you just, oh, I'm going to stick you on some steroids for a few days because of the itch. Well, you're going to take their blood sugar of 300 and make it 600, and now they're in a hyperosmolar state. You're going to wind up in the ER where you're going to kill them. So that's why one of the reasons why the use of steroids, you should always just take a moment to think. If I get ready to screw up here, okay, that'll probably happen a lot. If I get ready to screw up here. Also, it messes with the reabsorption in the kidneys of calcium and phosphorus. And if a person is on chronic steroid treatment, one of the bad problems that they will always end up with is osteoporosis. So if you have somebody you're treating with lupus, you're treating with daily steroids, understand that you're going to have long-term effects from that. Not only with bones, but with immunity as well. You know that steroids drop your immunity. And the way they do that is by, one, lysing T cells. CD4 positive T cells are responsible for humoral mediated immunity. CD8 positive cells, that's the cell mediated immunity up there. You're going to be messing with both of those. I told you the story about Dr. Amundsen and his ball sack. I didn't tell you that story?
Maybe.
This is a true story. Dr. Gerald Amundsen. You can Google him on the State Medical Board website. He's a real person. He's here in Oklahoma. Works out in Mustang. We used to go duck hunting together. And so he and I were, on the last day of duck season, nobody really duck hunts. It's mostly you just get beer and you go out in the watershed and you drink beer. And if a duck happens to come by, you usually just watch it fly away because you're not calling a duck, you're drinking beer. Anyway, he had pee. So he went over in the bushes and he peed. Well, the problem is he peed, and he was standing in poison ivy when he peed. And he had it all over his hands, you know, as we were, you know, getting through the woods. And now has it on his man parts. So about 2 days later, he was an attending at family medicine. About 2 days later, he had poison ivy, which is Rhus, capital R-H-U-S. Rhus is the genus name. Rhus dermatitis is poison ivy. It was so bad, when he was walking down the hall in his scrubs, it looked like he had a bowling ball in his pants. I haven't told you the story? I mean, his scrotum swelled enormously. Well, and it was so itchy, and so he would come down to the clinic and get a shot of steroids, right? So he did that for like 4 days in a row. What do you think steroids did to his immune system? Shut it down, which caused a reactivation of his varicella that he had when he was a child, and he wound up with shingles. So the shingles were so bad, and it's very painful, it can be very painful, that he started taking Percocets for the pain. Well, the Percocets is an opioid, right? And on your bowel, you have mu receptors, so the opioids block the mu receptor, or attach to the mu receptors, and not only do they decrease pain, they shut down your bowels. So everybody knows about opioid-induced constipation, because there's TV commercials about it, right? Well, now he was severely constipated with painful shingles and a scrotum that was that big. So he took, you know what mag citrate is? Mag citrate comes in a little green bottle like that, and it's very powerful laxative. And Jerry's a big guy. He lives up in Edmond. So he bought 2 bottles of mag citrate, and he started sipping on that one bottle as he was driving home to Edmond. And he got about halfway, and there was a traffic jam. And he stood still on Broadway Extension the same time that mag citrate hit the bottom. Well, the shit all over the inside of his car. So he had to get a new car. So that's the end of the story. Which goes to that bullet point. See, it's relevant. Any questions about that? I mean, to see him walking down the hall is like, bravo. Bravo. All right. Too much cortisol this is cortisol. It's Cushing syndrome, and it can come from many different causes. The most common cause of Cushing syndrome is iatrogenic. In other words, you took it, or you caused it as a provider. You gave somebody too much steroids for too long, and you caused iatrogenic Cushing syndrome. Secondary causes could be from, of course, a pituitary adenoma. It could be from an adenoma of the adrenal gland itself. Nodular hyperplasia is almost non-existent. Most of the time, if it's going to be from the adrenal gland, it's going to be a primary adenoma. The other thing you need to always pay attention to is a perineoplastic problem, like especially with small cell or oat cell cancer of the lung. Remember we were talking about these tumors secrete PTHRP and can give you false readings on calcium. The same thing can happen here. If you wind up with somebody with Cushingoid type syndrome, that's always a possibility. When you supplement cortisol, like if you're taking steroids, the adrenal gland, the cortex will shrink. Other things like stress will cause a transient hyperplasia. This is an adrenal adenoma. You see it's of the yellowish part, not of the reddish medulla. Adrenal adenomas are common. We've had, I don't know how many patients through Good Shepherd with little nodules on their adrenal glands. Usually when somebody comes in with a nodule on the adrenal gland, it's picked up by CT. Usually it's serendipity. You're looking for something else and boom, there's a nodule on the adrenal gland. Crap. There are different ways to approach them. One is you ought to go ahead and get a CMP that will tell you about sodium. The second thing is you get a cortisol level. And there's a thing called a cortisol suppression test where you challenge somebody with cortisol and withdraw it and see if they produce cortisol. But most of the time, you're just going to get a cortisol level. If it's less than a centimeter, you just watch it. If it's larger than a centimeter, then you need to send them to an interventional radiologist, and they will do an ultrasound-guided fine needle aspirate, FNA, fine needle aspiration of the nodule to see what it is. Most of these are benign, but they can be malignant. I had my receptionist over at OU died of an adrenal adenoma because they sat on it for several months, like 6 months, before they got around to actually doing an FNA. And when they did the FNA, it turned out it was malignant, and she died of it shortly thereafter. So I don't like nodules of the thyroid or any endocrine gland. I like to send them for biopsy. Okay? But they typically won't do it if it's less than a centimeter. Remember this pathway? You should be able to write this down in your sleep, if that even makes sense. Getting back to aldosterone and its effects on potassium and as well as sodium. Conn syndrome is hyperaldosteronism. Primary hyperaldosteronism, meaning it's coming from the adrenal gland, is called Conn syndrome. Regardless of what its origin, you see here we've got an adenoma here versus hyperplasia secondary to a pituitary effect. It's still Conn syndrome. Hyperaldosteronism is Conn syndrome. You have to really pay attention to a couple of things with people with Conn syndrome. One is, it's a cause of secondary hypertension. But as you see here, the percentage of people with hypertension with Conn syndrome as the culprit is very, very low. I've never seen a patient with Conn syndrome. The other thing you want to pay attention to are electrolytes, potassium and sodium. Congenital adrenal hyperplasia, we talked about this earlier, being a defect in 21-hydroxylase. This is the pathway where you get excess ACTH and excess androgen. In females, it causes masculinization. This is a congenital issue, so this is manifested at birth or shortly thereafter in males as precocious puberty. So they start developing secondary sex characteristics at the age of 4 or something like that. females, it can be pretty significant. This is the normal anatomy over here that you have. Over here in congenital adrenal hyperplasia, you have an enlarged clitoris to the point where it may appear as a penis. The uterus usually does not have its own opening through the vagina in the peritoneum. It usually is attached somewhere in the urinary system. You don't have a separate opening, because this is how you started out. This was your cloaca, right? This is what birds have now. You didn't compartmentalize them because of the excess androgen, so now you have one opening. That opening could be related to the clitoris. And then you have not a vaginal opening back here, but a fused perineum resembling a scrotum. In these examples here, these are all genetically female folks. You can see that, I mean, that right there with the rugated labia majora, what it actually is, it appears like a scrotum, with that being a penis. And because of the orientation of the urethra, they always have hypospadias. The opening of the urethra is always on that side, the ventral side. Okay? Thankfully, people, neonatologists and surgeons are much more sensitive to this, and they delay a lot of the assignment surgery until later and not get too aggressive like they used to. This is a couple of extra things about Cushing syndrome. I forgot I had that other slide about Cushing syndrome in there, and I said, oh crap, I didn't talk about Cushing syndrome, so I put this in here yesterday, but it essentially says the same thing as we said before. These people with Cushing syndrome, they're very characteristic, very characteristic. They have moon faces. And if you've ever seen a little kid or a person with a significant connective tissue disease that's on high-dose steroids, they always have round faces, moon faces. They have an excess deposition of lipids right here at their vertebral prominence, so it gives them a buffalo hump, looks like a buffalo hump. And they have central obesity, so you see the central obesity with little thin arms and legs. Very, very characteristic. And this summarizes all of that stuff here. A lot of symptoms, including hirsutism. They have excess hair growth. Women in the lip here and in other places on their face, around their neck, around their ears. It looks a lot like what other condition? What other endocrine condition gives you the same appearance? PCOS. PCOS. Other than the buffalo hump, they look a lot alike. Now PCOS also has, shares with it, glucose intolerance. That's the big thing about PCOS and Cushing syndrome. Diabetes, hirsutism, central obesity, moon face. In females, menstrual irregularities. What do you have in PCOS? Menstrual irregularities. Hypoadrenalism, primary acute adrenal cortical insufficiency is the other name for it. Basically, it's a sudden withdrawal of adrenal cortical function. This is also known as Addison's disease, or if it's a sudden acute withdrawal, it's called an Addisonian crisis. have to have cortisol to maintain blood pressure. If it suddenly drops to 0, your blood pressure is going to drop to 0. And probably the most common cause of adrenal crisis has to do with us. We have somebody on steroids, high-dose steroids, or moderately high-dose steroids, and then either we tell them to stop, or they stop it off, cold turkey, without tapering it off. Remember earlier on that slide that showed when you're taking when you're taking exogenous hormones, your adrenal glands shrink down. When you start taking hormones, it takes a few days before they start building back up. Those few days right there is when your blood pressure is zippity-doo-dah and you're dead. So, when you're putting somebody on steroids, the typical dose of steroids is 1 to 2 milligrams per kilogram. So, in that ballpark. So, Andrew, how much do you weigh?
150.
150 pounds, that's probably around close to 70 kilograms, right? About 70 kilograms. So he should be taking around a minimum of 70 milligrams a day, that ballpark. You don't have to be precise with dosing steroids, except when you're dealing with the very young. Prednisone comes in 20 milligram pills, 10 and 20 milligram pills. The easiest way to treat him, let's say he comes in with Rous dermatitis, not on the scrotum, but in a less sensitive place on his leg. I'm going to put him on steroids because he's itching himself to death. So what I'm going to do is I'm going to start with, I'm going to give you, this is the way the SIG is going to be. Let me back up. I'm going to write for prednisone 20 milligram tabs, okay? 3 tabs POQD times 3 days, then 2 tabs POQD times 3 days, then 1 tab POQD times 3 days. So you got that 60, 60, 60, 40, 40, 40, 20, 20, 20. That tapering is enough to prevent Addisonian crisis. Now, theoretically, you can put somebody, if you come in with asthma or croup or something like that, an upper airway thing, one of the treatments for is to give you steroids, decrease the inflammatory response. You can put somebody on 3 to 5 days of steroids, moderate dose, and not have to taper it. But once you get out to 9 days, you need to start tapering it. Now, why do I treat it? Why am I treating this for 9 days instead of just giving you 3 to 5 days? Well, because in Rous dermatitis and a lot of allergic conditions, if I treated you for only 3 days, 60, 60, 60, and stopped, you're going to wind up with a rebound reaction with the Rous dermatitis. All of a sudden, it not only comes back, but it explodes. That's why it's better to treat allergic dermatitis for 9 or more days. You just want to make sure you taper it versus a 3-day or 5-day treatment for upper respiratory issues. Okay? Now, some people that are on, that have things like arthritis or SLE, Sjogren's, not Sjogren's, the other connective tissue disorders, polyarthritis, nodosa, dermatomyositis, myositis, they'll be on 100 or 200 milligrams a day for a month. Now, if you stop that cold turkey, you're going to wind up here. So you want to taper them down over a period of a couple of months to get them off of it. Okay, remember that. Destruction of the adrenal glands, or the medulla, well, the adrenal glands in total, is called Waterhouse-Friderichsen syndrome. And it can come as a result of one of several things. One is that it can come as a result of trauma, car wrecks, that sort of thing. Two, it can be caused by infection, especially meningococcus. Three, it can be caused by anything that causes DIC. You know what DIC is? Disseminated intravascular coagulation. We talked about that back in Intro to Human Form in January. I'm sure you remember that well. So anything that immune reaction like that can produce, the adrenal glands turn into basically little sacs of blood. They're just, and they're non-functioning and they're dead. And so these people are hard to manage because you have to substitute cortisol in addition to dealing with the mineral corticoid. You're not worried about the testosterone so much. Okay? All right. Addison's disease, again, autoimmune adrenalitis. So, is that it? Okay. We're done.
I have a question. Does that Waterhouse, does it affect it bilaterally?
Yes.
So if you can manage that, why wouldn't you be able to resect both of them? Like if you
When I
can,
say manage that,
well,
maybe I didn't stress how impossible it is to manage these people. They are not going to do well. You can't take out both adrenal glands. You know, you can't take out both kidneys. There's some things you're just going to die. And, you know, it's really bad when you're dealing with little kids with meningococcus, or a college-age kid that gets meningococcal. This is before the vaccine. You know, now you wind up in the ICU, you gort your adrenals, and you know, these people die. What's the causative agent for meningococcus? What genus is it? What? No, oh, that slide up there where it says staph and strep and stuff like that, that's not what I'm talking about. I don't know what happened to it. What is the genus of the bug meningococcal? Is what? Neisseria. Neisseria. Yeah. Okay. Anything else? All right, I guess we have another lecture. I'll tell them you're done. Who is that? Is it Tammy or Brooks and me? Oh, that was funny. And I remember that this weekend. I thought about that this weekend. There was a woman that came in to family medicine. Oh, I can't remember her name. She had, only person I've ever known and talked to that had a prefrontal lobotomy. That she was functioning when she drove and everything, but when she came into the clinic, she was just talking to me, just talking about anything in the world. You know, the thing I wanted to do was go to the Brooks and Dunn concert, and I almost had tickets back in Arkansas. I mean, she was 100 miles an hour, and she would not stop. But she had that, she was crazy, she was bad shit crazy. But when you said something, when you just said, what did you say? Yeah, I just said Brooks and Dunn, Brooks and Dunn. So I just remembered her. Yeah, crazy. Okay.